Well, hello, my name is Adam Cuker. I am a hematologist at the University of Pennsylvania in Philadelphia in the USA. I'm delighted to participate in the meeting this year. I want to thank Mervyn Morgan and Professor Newland for the kind invitation. Today I'll be speaking to you about what is the current position of the thrombopoietin receptor agonists, or TRAs. And my goal during this talk is to answer a few questions about this important class of drugs. First, which TRAs are used to treat ITP? Second, how do they work? Third, are they effective? Fourth, what are the side effects? And finally, when should they be considered in the management of ITP? So let's begin with the first question. Which TRAs are used to treat ITP? Well, in the United States and in Europe, there are 3 approved thrombopoietin receptor agonists for the treatment of ITP, and I've shown pictures of them for you here. Romiplastim, the brand name is Nplate, Eltrombopag, which we call Promacta in the US, and which I believe is called Revelade in Europe, and finally Avatrombopag, or Doptelet. And this is a table that compares some of the key properties of these 3 drugs. So Romiplastim and Eltrombopag have been around longer than Avatrombopag. Romiplastim was approved for use in the US in 2008 and in Europe in 2009. Eltrombopag was approved for use in the US in 2008 and in Europe in 2010. Whereas Avatrombopag is newer. It was just approved for ITP in the US in 2019 and only received approval in Europe for ITP in January of this year. Now, I am an adult hematologist, and I'm going to be focusing my remarks primarily on the use of these drugs for the treatment of ITP in adults. But I do want to note that in addition to their approval in adults, Romiplastim and Eltrombopag are approved for treatment of ITP in children, whereas Avatrombopag is not, at least not yet. Eltrombopag and Avatrombopag are pills that are typically taken once a day or sometimes less frequently. Romiplastim, on the other hand, is a subcutaneous injection, an injection under the skin that is typically given on a weekly basis. There are some special considerations with respect to the administration of these drugs. Because Romiplastim is an injection, it is often given in a doctor's office, although I have certain patients who are able to give this treatment to themselves at home. Eltrombopag, again, is a daily pill, but it's important to note that it must be taken several hours removed from what we call polyvalent cations. What do we mean by polyvalent cations? Well, we're talking about things like calcium and iron and magnesium, which can interfere with the absorption of Eltrombopag. And that's why it's important to take it several hours removed from these molecules. And that would include, for example, dairy products, of course, which have lots of calcium. And so for some patients, it may be difficult to find a time in their schedule to take Eltrombopag removed from these polyvalent cations. And so Avatrombopag is an alternative pill that should be taken with food, but polyvalent cations do not interfere with its absorption. So you don't have to worry about taking it several hours removed from dairy, for example. So those are the TRAs that are used to treat ITP. Let's talk about how they work. Before we can do that, we need to talk about how thrombopoietin, or TPO, works. Thrombopoietin is a natural hormone that is produced by our liver. It gets transported to the bone marrow, where we make our blood cells, and it stimulates the bone marrow to make more platelets. That is the job of the natural hormone thrombopoietin. Now, there's a particular kind of cell in our bone marrow, megakaryocytes, whose job it is to make mature platelets. And so I want to take a closer look at what happens to the megakaryocytes with thrombopoietin and with the thrombopoietin receptor agonists. So here's a picture, and now we are essentially inside the megakaryocyte. This is the cell membrane. That's the outer lining of the cell. And below that cell membrane is inside the megakaryocyte, and above it is outside the megakaryocyte. And embedded within the cell membrane is a receptor called the thrombopoietin receptor, or c-MPL. And this star is meant to be a cartoon that to represent thrombopoietin, and thrombopoietin binds to this thrombopoietin receptor on the surface of the megakaryocyte. When it does so, it triggers a series of enzymes that ultimately leads the megakaryocyte to make more platelets and increase the platelet count. Romiplastim is very similar to thrombopoietin. It binds to the thrombopoietin receptor in the same place and essentially mimics the effects of natural thrombopoietin, again stimulating an enzyme cascade that leads the megakaryocyte to make more platelets. L-trombopag and avatrombopag are a little bit different. They too bind to the thrombopoietin receptor, but they bind at a different place. They bind down here within the membrane, what we call the transmembrane portion of the receptor. But they have a similar ultimate effect, triggering an enzyme cascade that ultimately leads the megakaryocyte to spit out more mature platelets. So I've talked to you about how TRAs work, but it's important to mention how they do not work. Unlike many other treatments for ITP, like steroids and splenectomy and rituximab, which counteract or interfere with the functioning of the immune system in some way, the thrombopoietin receptor agonists leave the immune system alone. They do not weaken the immune system, and therefore they do not increase patient susceptibility to infection. That's one of their important advantages. Okay, so we've talked about the 3 TRAs that we use to treat ITP. We've talked a little bit about how they work, but of course, the million-dollar question is, are they effective? And the short answer is yes, they are in the large majority of patients. What I want to do now is take you through the high-level results of the 3 clinical trials that led to approval of romiplastim, L-trombopag, and avatrombopag. This first one is romiplastim. In this clinical trial, there were patients with chronic ITP, 63 of whom had been splenectomized, 62 who still had their spleens. And these patients were randomly assigned to receive romiplastim or placebo, a sugar pill, for 24 weeks. The overall response was defined as a platelet count of 50 or higher for at least 4 weeks during the 24-week study period, and a durable response was defined as a platelet count of 50 or higher for at least 6 of the last 8 weeks on the study. And so here are the results. The green bars represent the percentage of patients who had a response with romiplastim. The red bars represent the percentage of patients who had a response with placebo. And what you can see, I think quite plainly, is that the response rates were much higher in those patients who were randomly assigned to romiplastim than those who got placebo. Overall response rates of 80 to almost 90% with romiplastim compared with 0 to 14% with placebo. And durable response rates of 40 to 60% with romiplastim and only 0 to 5% with placebo. So dramatically improved response rates with romiplastim or Nplate. What about L-trombopag? Well, in this trial, 197 patients with persistent or chronic ITP, that means they had ITP for at least 3 months, 71 of whom had been splenectomized, were randomized to receive L-trombopag or placebo, a sugar pill, for 6 months, 26 weeks. And this is a figure that shows what happened to the platelet counts in these patients. Here we have on the y-axis the median or middle platelet count among these patients. And on the x-axis, we have the study week. The green lines represent patients who were randomly assigned to receive eltrombopag. The peach lines represent those who were randomly assigned to receive placebo. And what I think you can see quite easily is that the median or middle platelet count levels in the patients assigned to receive eltrombopag were substantially higher than those who were treated with placebo. Again, underscoring the powerful effect of these drugs on the platelet count. Finally, that brings us to avatrombopag. This was a more recently completed and smaller clinical trial of 49 adults with chronic ITP, so ITP for at least 1 year. These individuals were randomly assigned to receive avatrombopag or placebo, a sugar pill, for 26 weeks. And here again, we're looking at the median or middle platelet count levels in these patients over the course of the study, and we have the weeks on study on the x-axis. The black line represents the platelet counts in the patients who were randomly assigned to receive avatrombopag. The gray line represents platelet counts in patients treated with placebo. And so what you can see here is that right from the beginning, the platelet count shoots up in the patients who were randomly assigned to receive avatrombopag, but not placebo. The platelet count then went a little bit lower because some of these patients had their platelet count shoot up too high. And so they had to have their dose adjusted downward. This is what was called the titration or dose adjustment phase. In the next phase, patients who were responding well were able to reduce their concomitant ITP medications, so drugs like steroids. And then finally, there was the maintenance phase. And you can see that through all three of these phases, the platelet counts were higher in the patients who were treated with avatrombopag compared to those who were treated with placebo. So benefits of the thrombopoietin receptor agonists. As I've shown you, they increase the platelet count. Now, not everybody with ITP has a platelet count improvement with thrombopoietin receptor agonists, but the majority of patients do. About 80% of patients will have an improvement in their platelet count with these drugs. And there are other advantages that come with an improved platelet count. First, a decreased need for rescue therapies. So many patients are able to decrease the dose or even discontinue entirely other medications like steroids. Not surprisingly, when you have higher platelet counts, this results in a decreased bleeding risk. And then finally, there have been studies that have shown that patients treated with thrombopoietin receptor agonists report an improvement in their health-related quality of life. And maybe this isn't surprising. Some of you have noticed perhaps that when your platelet count is higher, you have more energy. You may also just have less concern about bleeding risk, and that can be good for one's quality of life. And then, of course, rescue therapies like steroids have lots of side effects. And so there are benefits in terms of quality of life, in terms of being able to decrease the dose or get off of those rescue therapies. So lots of benefits to thrombopoietin receptor agonists. Now, the trials that I showed you only studied patients for like 24 weeks or 26 weeks. The question is then, is the response to the TRAs lasting? And the answer is yes. This is the result of, this is a figure from a extension study with romiplastim, where patients with ITP were studied after long-term treatment with romiplastim. You can see this study goes out to about 272 weeks. And here again, you're looking at the middle platelet counts. And what you can see is that patients are generally holding their platelet counts within a safe range between 50 and 200, and that tends to be stable over the course of the study. So when a patient responds to one of these drugs, they tend to maintain their response indefinitely as long as they stay on the drug. So the next question is, well, do you need to stay on a TRA forever? And the answer is yes, in most cases, but not always. So the way I like to explain this to patients is that thrombopoietin receptor agonists are different than a treatment like splenectomy, let's say. The goal of splenectomy is to do the surgery, and then hopefully afterward, the patient's platelet count is in a safe range and they no longer need treatment. TRAs are different. The expectation is that most patients will continue to need treatment in order to maintain a safe platelet count. I like to compare TRAs to blood pressure medicine. So many patients are on medication to control high blood pressure. If they were to stop their medication, their blood pressure would shoot up. And similarly, most patients with ITP, if they were to stop their TRA, their platelet count would fall. But we now know that there are a fraction of patients who are able to safely discontinue TRAs and maintain a safe platelet count off all treatment. And I've summarized for you the results of 4 studies that show this observation. So here's a study where 75 patients treated with romiplastim were observed. Remission was defined as a platelet count of 50 or higher for 24 weeks with no ITP treatment. And 32% of these patients were able to come off their romiplastim and meet this definition of remission. That is, maintain a safe platelet count for at least 24 weeks with no ITP treatment. Here's another study with L-Trombopag. Again, about 33% of patients were able to meet the definition of remission, a platelet count of 30 or higher for at least 6 months with no ITP treatment. Another study where patients on either romiplastim or L-Trombopag were observed, 29% were able to come off their TRA and meet the definition of remission. And finally, a study of 80 patients on L-Trombopag, 33% of whom were able to come off their L-Trombopag and maintain a safe platelet count of 30 or higher for at least 6 months with no ITP treatment. So what I tell my patients is that most of the time, patients with ITP will need to continue their TRA indefinitely in order to maintain a safe platelet count. But there are a fraction of patients, perhaps a third, who are ultimately able to safely discontinue their TRA and maintain a safe platelet count off all treatment for a period of at least months and perhaps longer. Now, what we don't know is whether the TPO-RAs are actually causing these remissions, inducing these remissions, or whether these are simply patients who were destined to have an improvement in their ITP over time, and maybe they just needed the TRA as a bridge to get to them to that point where they were going to have spontaneous improvement in their condition. We don't know that yet, but there are clinical trials that are going on now that will help us to understand whether TRAs may actually have the ability to induce remissions in some patients. Okay, well, we've talked about the effectiveness of the TRAs. What about the side effects? Well, the most common side effects, those that occur in 10%, more than 10% of patients, include things like headache, fatigue, bone or muscle pains, and then non-specific gastrointestinal symptoms like abdominal cramping or diarrhea. Then there are the less common side effects, which tend to occur in 10% of patients or less, but are potentially more serious. These would include things like blood clots, which occur in about 5% of individuals. Blood clots can be in the arteries, things like heart attacks or strokes, or they can occur in the veins, events like deep vein thrombosis or pulmonary embolism. It's important to note that most of the patients who have developed blood clots on these drugs had pre-existing risk factors for clotting. And so one of the things I do when I'm thinking about whether to put a patient on a TRA is to assess whether they have pre-existing clotting factors. Another side effect is bone marrow fibrosis or scarring of the bone marrow. Fortunately, this is quite rare. It occurs in only about 1% of individuals, and it appears to be completely reversible. So if somebody does develop significant bone marrow fibrosis, rare though it is, when their TRA is stopped, the fibrosis disappears. About 10% of patients who are treated with eltrombopag will develop abnormalities of their liver blood work. And so one of the things that we do in monitoring patients on eltrombopag is to monitor their liver blood tests periodically. This side effect appears to be primarily an issue with eltrombopag. And so if a patient were to develop liver blood test abnormalities that require them to stop their eltrombopag, they would be eligible to receive one of the other TRAs. And finally, there may be a small increased risk of formation of cataracts in patients with eltrombopag. But again, this appears to be a small risk, estimated at about 1%. Now, you may not be used to thinking of cost as a side effect, but more and more, at least in the US, we are thinking about cost as something that we call financial toxicity, another adverse effect of the drugs, if you will. And indeed, these agents are quite expensive. And what I've done for you here is summarize how much they cost in the United States. I don't have cost data from the United Kingdom or elsewhere. My suspicion is that the drugs may cost less in other countries because of your health systems, but they are very expensive, particularly in the United States. So for example, if we look at a typical dose of romiplastim, which would be 3 micrograms per kilogram per week in a 70-kilogram individual, an annual US cost for that dose would be about $129 US, which equates to about 93,000 pounds per year. What about eltrombopag? A typical dose would be 50 milligrams per day. An annual cost for that dose in US dollars would be about $149,000, which equates to about 107,000 British pounds per year. And finally, avatrombopag, a typical dose might be 20 milligrams daily. The annual US cost in US dollars, about $143,000, which would equate to 103,000 British pounds. So these are very expensive drugs. Not every patient can afford these drugs depending on their particular insurance. And so that is an important factor that we need to weigh when considering whether to use these agents. Okay, well, we've talked about the side effects. The last thing I wanted to discuss is when should TPO-RAs be considered? They are not for everyone with ITP. So how do we decide when to use them? Well, this is a slide that summarizes the sort of conventional treatment paradigm for adults with ITP. And I'll take you through this now. Our typical goal is to achieve and maintain a safe platelet count, 20 to 30,000 or higher for most patients in most situations, while at the same time minimizing the side effects of treatment. And so patients who have baseline platelet counts above 50 rarely require treatment, and we can usually manage those patients with observation alone. On the other hand, if the patient has a platelet count of less than 30, we typically treat them with first-line therapy. And first-line therapy consists of corticosteroids, drugs like prednisone, supplemented as needed with IVIG or with anti-D. Now, occasionally patients will respond well to first-line therapy and maintain their response. And so if they do, if they have a stable platelet count of greater than 30 to 50 after first-line treatment, they probably don't need additional therapy and they can just be observed. But most patients, even those who respond to drugs like steroids, will have a relapse when their first-line therapy is tapered. And that's when we move on to second-line treatments. And you can see among the options for second-line treatments are thrombopoietin receptor agonists, along with rituximab and splenectomy. And I'll just mention it's the relatively uncommon ITP patient who does not respond to or cannot receive any of these second-line treatments and then needs to move on to a third-line treatment. So how do we decide in a patient who needs second-line treatment whether to use TRAs versus rituximab or splenectomy? Well, it's a complicated decision pathway, but this is a slide from the American Society of Hematology ITP guidelines that sort of gives you a sense about how we approach this question. So the first thing we do if we have an adult with ITP for at least 3 months who is dependent on or unresponsive to steroids is we think about how long they've had their ITP for. If they've had their ITP for 3 to 12 months, so less than a year, we would prefer to avoid splenectomy. And that is because remissions, if they're going to occur, tend to occur in the first year after diagnosis. And we would prefer not to remove the spleen of somebody who is destined to remit in only a few months. And so therefore, if somebody's had ITP for only 3 to 12 months, our primary treatment options for second-line therapy are going to be rituximab or the thrombopoietin receptor agonists. And to choose between these options, we might consider a number of factors, but one of the important factors we consider is the patient's values and preferences. If the patient places a high value on achieving a durable response, then we're probably going to go with the TRA because they have significantly higher response rates than rituximab. On the other hand, one of the advantages of rituximab is that you're given a few infusions and then you're done with your treatment. And so if the patient places a high value on avoiding long-term medication, they may prefer to try rituximab first before a TPO-RA. Now, what if the patient has had ITP for more than 12 months? Well, now then splenectomy becomes an option, along with rituximab and the thrombopoietin receptor agonists. Once again, we would consider a number of different factors in choosing the best treatment for the patient, but a really important factor, again, is to assess the patient's values and preferences. And many of our patients place a high value on avoiding surgery, so they would rather try medical therapy over splenectomy. And if that's the case, the main treatment options are going to be a TPO-RA or rituximab. And once again, if the patient places a high value on achieving a durable response, a TPO-RA may be the best choice. If the patient places a high value on avoiding long-term medications, rituximab may be preferred. And so this is the sort of exercise that I go through with my patients, is trying to lay out the options, the pros and cons of the various options, and really trying to understand their values and preferences so that we can come to a decision together that best aligns with the patient's individual preferences. So let's go back to our treatment paradigm, and I quickly want to talk a bit about corticosteroids, the backbone of first-line treatment for ITP, and why it may be time to rethink our paradigm. So I think that there is a bit of a folly to the way that we use steroids in ITP. Don't get me wrong. I think that they're a very valuable treatment for this disease. They're inexpensive. They work in the large majority of patients. They bring the platelet count up quickly. They can be lifesavers. But what do I mean by the folly of steroids for ITP? Well, the first point is that most patients respond to steroids, about 80 to 90%. This is a figure that shows newly diagnosed ITP patients treated with steroids. And CR plus PR stands for complete plus partial remission. And you can see that the large majority of patients achieve a remission with steroids or a response, usually within the first few weeks of starting treatment. The problem, of course, is that when you take the patients off steroids, when you taper them, they tend to relapse. And that's the point underscored by this figure. This shows you patients who had a response to steroids, and then their probability of maintaining a response after the steroids are tapered. And what you can see is that over a 10-year period, only 13% of patients were free of relapse. That means 87% of patients who had responded to steroids relapsed, usually within the first few months after the steroids are tapered. So the point here, if you look at these curves, is the platelet count goes up with steroids, and then when the steroids are tapered, the platelet count goes down. And I like to call this the steroid roller coaster. You know, you can imagine the patient's platelet count going up, and then when we take them off steroids, the platelet count goes down. But of course, the roller coaster analogy works on a second level with steroids, right? Because in some ways, we're putting patients through an emotional roller coaster because of all the side effects with the steroids that they experience. I don't need to tell you all the things that steroids cause: a swollen face, acne, the buffalo hump, increased weight, stretch marks on the abdomen. And of course, this isn't to mention all of the effects that corticosteroids have on your mood. They can cause depression, irritability, anxiety. I sort of like this meme which says, the good news is prednisone will help to pull you out of this flare. The bad news is your family might want to take an impromptu trip without you for the next 6 months. That speaks to the effect that steroids can have on a patient's personality. And so why do we put patients through this steroid roller coaster? Why do we treat them with steroids if we're pretty certain that their platelet count is only going to fall and they're going to need to move on to second-line treatment? And so I would suggest it's time to rethink this paradigm, and perhaps we should stop using steroids so much in our patients with ITP and consider moving directly to second-line treatments like thrombopoietin receptor agonists. And indeed, there are clinical trials going on now that are testing the role of using thrombopoietin receptor agonists as first-line treatment for ITP, as a means of helping patients to avoid the need for prolonged and excessive steroid exposure. So in summary, this is my final slide. We talked about which TRAs are used to treat ITP, and we mentioned the 3 that are approved for use in the United States and the United Kingdom: romiplastim, eltrombopag, and avatrombopag. We talked about how these drugs work. They stimulate the bone marrow to make more platelets, and they specifically do not interfere with or weaken the immune system. Are these drugs effective? Well, yes, as we discussed, they increase the platelet count in about 80% of patients. They also reduce bleeding, reduce the need for rescue therapy, and improve quality of life. But they have important side effects. Side effects include common things like headache, fatigue, muscle aches, and GI symptoms, and then less common but more serious events like clots, blood clots, and abnormal liver tests. Most patients are able to find these side effects tolerable, but they can have an important negative effect on patients' lives. And then finally, when should these drugs be considered? Well, they are considered currently as an option for second-line treatment after the patient has received first-line therapy, including steroids. But as I just noted, we are now beginning to wonder whether they might be useful as a first-line treatment, potentially in place of steroids, and clinical trials to address this question are ongoing. So I will conclude there, and I thank you very much for your attention.